next speaker is Dr. Mark Johnson. He has a PhD in clinical health psychology and behavioral medicine from the University of North Texas and completed medical psychology rotations at Duke Medical Center. His specialties include chronic pain, sleep, and co-occurring mood disorders. Sounds like he's in the same good room, huh? And Dr. Johnson has been with the Bay Area Pain and Wellness Center since 2014. Dr. Johnson.
It's an honor to be at the tail end of such heavy hitters here today. They're a hard act to follow. There's been a number of things that I'd like to touch upon that each have said. And I hope that you're going to hear some overlap in what I have to say, because that's a big part of what we do. There's a distinction between an interdisciplinary program and a multidisciplinary. Multidisciplinary can have multiple components, but not necessarily dialoguing with each other, not necessarily a team effort. And the type of work that we do as an interdisciplinary program, we do have a lot of overlap, a lot of repetition, a lot of teamwork, and a lot of everybody focusing on patients together. So to segue a little bit off of some of what Dr. Massey said, there's, in a review of evidence-based literature, there's been questions that have been asked as far as, do individuals with CRPS have psychological differences compared to other pain populations? Again, that whole idea of if this is so out of proportion and there's not really a medical explanation for it, you know, is there something different going on with these individuals? There's no evidence of that. And there's also been questions as far as, was there some type of pre-existing condition? Was there some significant anxiety or depression or other conditions going on prior to the condition? And once again, there's no evidence of that. So what we do know is that patients with chronic pain tend to be more likely than the general population to develop psychological disorders. And so, as others have been saying, if you're dealing with intense chronic pain on a daily basis and it's disrupting, you know, every aspect of your life, there's going to be a high level of probability that's going to lead to more worry, more anxiety, more depression, and so forth. Anxiety and depression are positive predictors of pain, as well as the number of medications a person takes, as well as their perceived level of disability. Depression can do a whole bunch of things. It can impede recall of changes in pain levels and alter a person's perception of pain. Experiencing a day of depression can predict a following day of increased pain. And these are just some of the big ones, but other things get affected too. There's been some research that individuals with CRPS, it may also affect their ability to empathize with others, which makes sense. If you have a body part that's constantly screaming at you, it may be harder to sort of feel what you need to feel for some of the other significant people in your life. So there are these social disruptions. It's been suggested that people with CRPS do pretty well initially. There's a minimal psychological response. But over time, over the course of 6 or 8 weeks, more things start to take their toll, and then it is recommended that there's some psychological assessment to go with that. This is just a quick model that's very relevant in the physical therapy components of our program, which is the person who's injured and experiencing pain often may go into those catastrophizing thoughts, which can lead to a lot of pain-related fear, activity avoidance, further disuse, further disability, further depression, which just keeps cycling inward. And so a big part of the way that we treat pain is to try to confront that and see if we can get people to be able to move and be active despite the fact that they have pain, and maybe learn that the consequences aren't as bad as they think. And probably when we do have people, which occasionally happens, people that leave the program very early after just a few days, it's usually because their pain does increase There's a lot of fear around that. There's the idea of this is making me worse, and then people sometimes bolt based on that. So when it comes to the psychological aspects of this, it's looked at more as an interaction rather than a cause and effect. And the idea is that the person who's having psychological distress, whether it's pain-related or whether it's non-pain-related, it can involve maladaptive cognition, such as catastrophizing, thinking the worst-case scenarios. It can also involve dysphoric emotions, such as anxiety and depression. That is thought to feed into some pathophysiological mechanisms. So initially, a stress response in the body based on acute stress is a good thing. It's going to have some anti-inflammatory effects, but when there's a prolonged stress response, you start to see some cortisol dysfunction, you start to see increased inflammation as well as formation of fear-based memories, and all of that can initiate, exacerbate, or even prolong the pain experience, as well as lead to things like central sensitization. So these are kind of proposed models of what might be going on for the person who is experiencing a more and more persistent situation. There is some evidence that life events might precede CRPS. This would basically be negative life events. And the idea is kind of what I was just talking about. Based on a repeatedly triggered sympathetic system, it could create prolonged increased autonomic arousal. And again, you start seeing those results that we were just talking about. So research indicates that children with CRPS report more negative life events as well as more family-related life events. There's also been some very recent research. I think this was a 2017 article that just came out very recently. Of 152 patients with CRPS, 58 of them, or 38%, had had life events prior to the CRPS onset that had PTSD associated with it. I've also heard numbers up to as high as 90% of individuals, but again, most of the evidence-based research I've been reading is suggesting that we're still in the some evidence range of this. And there's also tends to be a higher incidence of females. Again, different literature will suggest there's a 3-to-1 ratio, 4-to-1 ratio, 5-to-1 ratio, but it does seem that this is afflicting females more than men. And there's also some evidence of hereditary influence that correlates with an earlier onset. When you see younger individuals develop CRPS, there tends to be some other family members that have been dealing with that as well. Some other things I wanted to touch upon is just some of the assessment and treatment issues. And then after that, I want to follow up talking about the outcomes that our clinic gets. So in terms of psychological assessment, we do like to try and identify any significant ongoing stressors that individuals may be having. We look at early life stressors, we look at stress at the time of injury, we look at stress since the injury. We're basically looking for those factors that could cause that heightened sympathetic response, that overactive sympathetic activation for individuals that could be, again, maintaining or exacerbating. We try to identify any co-occurring conditions such as depression, anxiety, panic, PTSD. If those are present, we try to target them specifically. And we do that in a variety of ways. Sometimes people want to address those things while they're in our program. Sometimes people kind of want to hold off and wait. And so we do have people that complete the 6 weeks of our program and then come back and continue with individual psychology follow-ups. We're looking in general also at cognitive, emotional, and behavioral responses, adaptive versus maladaptive types of coping, and even the responses of significant others. I was really glad to hear Dr. Mackey talk about the power of love, and sometimes that's a potent factor that comes up for people throughout the course of treatment. Is at a certain point they say, hey, you know what? I'm kind of realizing that in addition to everything else, I want to work on my marriage, or something that's really at the core of their life. I've seen a few people at the end of the program, a short while later, end up going through divorces. Other people sometimes want to bring in their family members, and that's always welcome in our clinic too, if people are trying to work those things out. In terms of interventions, I tried to kind of separate two categories here. One, I see the role of psychology in our clinic as highly supportive to the other components of the program. So some of the things that we're trying to address is that hurt versus harm. A big cornerstone of our program is just education. And we like to sometimes say tissue is not the issue. And look at the fact that an individual may have that fear that this hurts, so I'm not going to do it. And that fear of movement, again, can lead to disuse, avoidance, that can lead to a host of complications and a worsening of the condition. So we do support those exposure techniques as well as a lot of relaxation-based techniques. In addition, we do really focus a lot on relaxation training to increase a sense of control over a person's pain, as well as decrease emotional arousal. We target some of the maladaptive thoughts that could be fear-invoking for individuals. Again, we'll focus specifically on any mood-related issues that come up. Definitely including sleep, that was mentioned, and that's always a big one for people. And we'll address any family issues that may come up and just teach general pain coping skills in general. So it's a very holistic kind of approach, which really has to make sense because there's only so much you can do to a body part. And if somebody has been taking medications, injections, surgeries, again, a body part can only take so much. And if you've got a lot of other factors that are contributing to the condition, it really makes sense to address all of them. And theoretically, it should have a palliative effect for individuals. There was an interesting research piece that came out, which was based on advice from CRPS patients to CRPS patients, people who had gone through some good improvement. And all of their input was categorized into the main theme of playing an active role in regaining control. Again, that's a big part of what we're trying to do, is get people to move away from passive modalities, passive therapies, and go more into self-management and active control of their condition. Some sub-themes were acceptance, and the idea of acceptance is it's not something that has an endpoint to it, but it's sort of something that people continue to grapple with and kind of move in and out of. Gaining the right support, meaning the people in your life who are trying to support and help you are actually supporting and helping you, not working against you in any way. And becoming informed, just getting the information and the education. I think there's been a lot of that here today. Interdisciplinary pain management is recommended for CRPS. People who complete it show increased positivity, feelings of being understood, feeling validated, perceiving that they're starting to take back some control over their lives, which is really important. And significant improvements have been shown in these areas. I just want to say that this is based on pretty scant literature. There's not a lot of information, and one of the first studies, I think, that was maybe around 2004, was based on 12 people in the program. And so we usually see pretty small numbers, and there's only a few, but they do show improvements in physical functioning and perceived disability, better adaptive coping, more pain acceptance, less emotional distress, reduced meds. Of note, pain intensity often does not reduce to a great deal. However, people that go through our program often will say, my pain is about the same, but I'm more flexible, I'm stronger, I'm doing more doing a lot of things I didn't think I could do. I'm functioning better, my mood is better, my sleep is better. And so it tends to be a win. People are kind of like, so many other things change, I'm not even worried about this as much anymore. So I'd like to just share the results we've been getting now. And I thought the most interesting way of doing this would be to compare to what we're usually seeing in the general population we serve, which tends to be just all different body parts, multiple injuries. We don't really cherry pick into any specific thing. We're treating a lot of things. And when it comes to kinesiophobia, or the fear of movement, we tend to see with individuals with CRPS about an 11% reduction, meaning improvement. And compared to our general pain population, it's about the same. In terms of activities of daily living, the direction of coming down means less disability for individuals. So this is a good direction. This means better functioning in activities of daily living. Our general population improves by about 16%. Individuals with CRPS, again, are around 11. So a little bit less improvement in terms of this category. In terms of pain intensity, this was what I was saying. We only see a very small level of improvement in pain intensity, but in terms of pain interference, this was probably one of our largest effects, which is close to 25% decrease in pain interference. So again, the pain is interfering a lot less, and that's even better than it is for our general pain population at 22%. We see improvements in depression and anxiety that are very comparable to what we see with others that we treat. 27% improvement for depression, 30% for anxiety. What that actually means is if somebody comes into the program saying they're moderately depressed, they might finish being in the mild category. So it's kind of a full jump. Same thing with anxiety. It could go from moderate level to mild or severe to moderate. In terms of coping, this is our measurement of either illness-focused coping, of kind of guarding, resting, protecting the area, versus wellness-focused, which is more active pain management. And our two largest effect sizes are, again, the same, pretty close to the same for general, actually even a little bit better for individuals with CRPS, which is a lot more use of exercise and relaxation to cope with their pain. And one more thing I wanted to mention is what Dr. Abachi started with this morning was that really the big goal is, can people be happy while being challenged with CRPS? And I think that's what we often see coming out of our program is people saying, this transformed me, I kind of got my life back, a lot of things changed. You know, the pain is still there, but despite the pain, people are getting back to feeling like they've got a good life, they're more in control, they're doing better self-management. And as Dr. Massey was saying, our goal is to get people out of the medical offices, you know, getting your lives back, living the best quality of life you can, and not having to rely as much on patienthood.